Hello, welcome to CIRS and Overwhelm. I am Jenny Johnson. I'm a physical therapist, a functional medicine nutritionist and coach, a Shoemaker proficiency partner, and I function as a CIRS coach, consultant, patient educator, and support group facilitator. This talk is for the CIRSx conference in Fort Lauderdale of April 2022. I have nothing to disclose. Here's an overview of what we'll be talking about today. I'm first going to offer some definitions of what overwhelm is and how it is relevant to the CIRS population. We will discuss the relationship between overwhelm and trauma. We will talk about the physiological effects of overwhelm and perceived lack of safety and how these can serve as obstacles to CIRS recovery. We'll be talking about some questions and potential correlations that we could consider. I will share some ideas for how to identify patients who are at risk of pathological overwhelm, as well as strategies for helping them either to prevent or break the positive feedback loop of overwhelm, inflammation, and nervous system dysregulation. So let's go ahead with our definition of overwhelm. These are just several definitions that I got from dictionaries online, but I think they do a pretty good job of capturing what I'm aiming to talk about today. Number one, the numb feeling of desperation we experience when life seems to be spinning out of control. That word numb is kind of key, I feel. Similar to the first word of the next definition, incapacitating emotional or physical stress. Third one, the subjective sense of being overpowered, overloaded, or defeated. Keyword there might be subjective. Fourth one, feeling unable to cope with the demands placed upon us. So question is, are our CIRS patients overwhelmed? I like this patient or this picture of just everything coming at us at once. This is how I felt as a patient undergoing CIRS and how I know a lot of my clients feel. I don't know if your patients or clients feel the same way that mine do. I am a coach for folks who may need a little bit of extra support. And so I do get most of my referrals from doctors who send me those people who are needing a little bit more support than maybe the next person. So my impression may be a little bit biased here, but I will say that overwhelmed is absolutely the number one descriptor I hear from CIRS patients. When I first meet with them, if I've met with them even several times in my support groups, I'm so overwhelmed. I'm just so overwhelmed. I hear this every day, and this is why I became curious about what this really means and how it may impact our CIRS journey. So what are the sources of overwhelm for our CIRS patients? These are some ideas that I came up with. You may have more. But the number one here that I feel is a source is sensing that our safety is in immediate danger, but that we don't have the resources to protect ourselves. When our sanctuary, our home, or maybe our work is threatened, when we have found out that we have biotoxin exposure that may be coming from our place of perceived safety, and we no longer have that sanctuary available to us, it's extremely threatening. And when we feel that this is the reason, or we learn that this is the reason for our significant symptoms, this feels very acute and dangerous, that I am so sick because my house is sick, essentially. And then if we don't have the resources to do anything about it, maybe time, maybe it's just going to take time, maybe it's money, maybe it's energy, maybe it's practical support or emotional support from a spouse. Maybe it's professional support, finding the right IEP and doctor to help us through this. I think I said finances. If I haven't yet, finances, that's a huge one. But these are the resources that we need to mount a proper response to meet this need or this threat, to mitigate this threat to our safety. And many people don't feel like they have sufficient resources. Another source of overwhelm is a complicated treatment plan or environmental plan, or even just a complicated daily regimen. Some of our patients and clients feel that there's just too much information or not enough information or conflicting information about CIRS and biotoxin illness and how we treat this and what the proper way to address our home may be. And this can be very overwhelming, especially when people don't yet have those professional supports in place. So let's talk about overwhelm and previous trauma. This is interesting to me, and I hope that it's interesting to you as well. But having a history of unresolved trauma can lower our threshold for overwhelm and decrease our coping skills. Also, the subjective perception of overwhelm can be a trigger for previous traumas or PTSD, inducing a trauma response in our nervous system. We're going to be talking in just a little bit about what that trauma response in our nervous system is. Here's another interesting idea. When CIRS and overwhelm become a new trauma, I think many of us for a long time have thought of trauma as an event that happens to us rather than our subjective perception of an experience or an event, and then our physiological and emotional and mental response to that subjective experience. Here are a couple of actually definitions of trauma from trauma specialists in the world right now who are trying to redefine what trauma is, or maybe clarify the misconceptions out there. The first one says, trauma is the response to a stressful or disturbing experience that overwhelms our ability to cope. Here's another one from Dr. Amy Apigian of Biology of Trauma and Trauma Healing Accelerated. Trauma is not an event, but a felt experience that causes overwhelm on a cellular level. There's a connection between trauma and overwhelm. Again, to summarize, what we've learned so far is that previous trauma can lower our threshold for future overwhelm, making overwhelm happen more often, and that overwhelm itself can be or induce a new traumatic experience or new traumatic response in our nervous system. So what is the biology or the pathophysiology of overwhelm? We're going to talk about this because I think this is really interesting. There are different components of this. The first is limbic impairment, also considered altered neuroception. We'll also be talking about HPA axis dysregulation and acute stress versus chronic stress. I'll share some information about the polyvagal theory and the autonomic nervous system dysfunctions. And then finally, we'll talk about overwhelm and the freeze or trauma response and what that looks like. So let's start with the limbic system. Here's a rudimentary picture over here depicting the various structures that most professionals agree are a part of the limbic system, at least some of them here. And what we're talking about most often is a hypervigilant limbic system when our threat detection center, primarily our amygdala, maybe is overactive, hyperactive, and perhaps our prefrontal cortex and our cingulate gyrus that might govern our amygdala and its impact on our HPA axis and on our autonomic nervous system down the line. When our prefrontal cortex and cingulate gyrus are not or maybe have diminished activity or blood flow, then there's less of that governance, so we can have that hypervigilant limbic system. There are various things that can prime a limbic system to become hypervigilant. One is physical or emotional trauma in our history. Another is neuroinflammation itself. So most of our patients maybe are already set up for a hypervigilant limbic system just because of the brain inflammation and primed microglia. And then a perceived lack of safety or fear. This could be just how somebody is wired, their personality, or it could be even maybe induced by the way that we as well-meaning clinicians and coaches and consultants speak with them, trying to get them to appreciate and understand the gravity of environmental exposures. We may actually induce a bit of a hypervigilance in their limbic system by creating fear and a sense of lack of safety. So again, the downstream effects of a hypervigilant limbic system are maybe increased activation of our HPA axis, the production of excitatory neurotransmitters, and the activation of our sympathetic nervous system, which is our fight and flight system. So speaking of our autonomic nervous system, let's do a quick review here of the parasympathetic and sympathetic responses and systems. I have over here on the left, the sympathetic nervous system depicted in red. When I talk about this with my clients, I talk about being in the red zone and identifying with what does that feel like in our body when we're in the red zone, when we feel anxious or afraid, our heart rate is beating fast, might feel kind of flushed or sweaty. This is a sign that we're in the red zone. It is dominant during times of stress or perceived stress. It enhances our blood glucose, our heart rate, our blood pressure, skeletal muscle blood flow to meet the challenge of a stressor or perceived stressor. Blood and energy are shunted away from activities of digestion, detoxification, reproduction. This system is associated with panic, anxiety, sleep disturbances, and indigestion. So clearly not ideal for recovery from a chronic illness, being able to detox and digest food and have good gut health and whatnot. And then in green, we have the parasympathetic nervous system. Again, I call this the green zone with my clients. This is where we ideally want to be as our resting state. It is dominant during times of perceived safety and social connection. It activates detoxification, tissue repair, digestion, reproduction, blood sugar balance, and much more. So obviously this is where we want to be for optimal healing and recovery from a chronic illness such as CIRS. So homeostasis is the normal fluctuation between parasympathetic and sympathetic when we need to go there, when there is a stressor that that demands more blood flow and an increased heart rate and increased blood sugar. Absolutely, that happens, and we need to shift into sympathetic. But we don't want to stay there unnecessarily long. We want to be able to flip back to our resting state of parasympathetic. That is normal homeostasis. We do the back and forth, and we're resilient. So let's talk a little bit about the polyvagal theory. This was developed by Stephen Porges, and the concept here is that there are 3 states instead of 2. So we still have the sympathetic nervous system. That's pretty much the same, governed by the sympathetic chain. And we associate that with fight and flight. And you can see that here depicted in red on the graph in the middle. And then we have the green zone, but instead of just calling it the parasympathetic state, Stephen Porges calls it the ventral vagal, or the ventral branch of the vagus nerve, which governs this state. It is also the parasympathetic state, as most people understand it. But the idea here is that cranial nerve 10, the vagus nerve, branches off into 2 different directions. We've got the ventral branch and the dorsal branch. And the ventral branch is associated with the parasympathetic state and everything that we typically see with that: the digestion, intestinal motility, resistance to infection, immune system regulation, rest, recuperation, tissue repair, all kinds of good things for healing. And then the dorsal branch of the vagus nerve of cranial nerve 10, this one is interesting. Here's where things differ from the classic theory of just sympathetic and parasympathetic. The dorsal branch of cranial nerve 10 is what Stephen Porges posits is causing the freeze or the trauma response. And what's interesting is that according to our classic system, the sympathetic chain is associated with fight, flight, and freeze, Yet the freeze response physiologically and biochemically is totally different. It's actually quite opposite the fight and flight. So it's not really sympathetic, yet it's not also the rest and digest and heal state either. It's actually quite inconducive to resting and digesting and healing. So it's really a third physiological state. And again, Stephen Porges posits that it's governed by the dorsal branch of cranial nerve 10. This is associated with shutdown, dissociation, low cortisol, low DHEA, low dopamine, low serotonin, depression, shock, low muscle tone, POTS, indigestion, chronic pain, chronic fatigue, insomnia, brain fog, executive dysfunction, chronic inflammation, low metabolism, swallowing difficulties, and suicidal ideation. This is essentially a protective response when stress turns to overwhelm. And if you think back to those original definitions that we talked about of overwhelm, the words numb or incapacitated were included in the definition. And those are literal words. People feel frozen. And it's a protective mechanism. When we can't mount a response to fight or to flee from a threat, we freeze or we play dead. And physiologically, our systems shut down as well. And clearly, this also, just like the sympathetic overdrive, the dorsal freeze or trauma response or the overwhelm response is also inconducive to healing and recovery. So here are some questions that I'd love for us to consider. Could overwhelm be contributing to CIRS inflammation and multisystemic symptom presentation through its impact on the autonomic nervous system? Or does the inflammation caused by CIRS predispose us to a dysregulated nervous system and the experience of overwhelm and trauma? Is it the chicken or the egg? Does perceived overwhelm during CIRS or CIRS treatment play a role in upregulating our PTSD gene, the FKBP5? How can we identify patients who are most at risk for pathological overwhelm? And lastly, how can we prevent or mitigate overwhelm and new trauma in the way that we care for our patients? And would this impact their rate of recovery or their outcomes? So let's talk about identifying at-risk patients. Dr. Michelle, in a recent iDog, I Dream of Jeannie conference, talked about the FKBP5 gene and how she's seeing it upregulated in about 30% of her clients or her patients in her clinic, but that she sees even more people, I believe, demonstrating a trauma response. She thinks that there's even more who are maybe at risk for kind of a negative impact perhaps on their CIRS journey due to a trauma response. She didn't word it that way, but something curious about maybe even the genetic expression maybe underrepresenting the people who are impacted by this. And she shared with us the use of the ACE score, and in particular, the score of 4 or more on this questionnaire as really key, as a red flag in identifying people with previous trauma. Now, again, we talked about how people with previous trauma may be more at risk for overwhelm and the physiological response of overwhelm, because overwhelm can trigger previous traumas. So looking at someone's previous trauma can certainly be a good indicator of someone's susceptibility to overwhelm. The International Trauma Questionnaire is another form that Dr. Michelle brought up in her talk. I think it was in October of 2021 at the iDog conference. And she shared how this identifies more broad types of trauma, including complex trauma. So this might be a good one to include instead of, or maybe in addition to, the ACE score. But there are two additional questionnaires that I've looked into that are interesting to me. One is called the Brief Resilient Coping Scale, and the other one is called the Brief Cope. And the reason why these are interesting is they identify real-time current personal subjective assessments of coping strategies. And so instead of just looking at previous trauma, which we know can put somebody at risk for this overwhelm and the freeze response in their nervous system, somebody doesn't have to have previous trauma, and especially not an ACE score of 4, to be so overwhelmed by their CIRS journey that they are in a trauma response currently. And so trying to identify these patients by types of questionnaires that get at current coping skills. How are you feeling with everything that's on your plate? Do you feel that you have what it takes to get through this? Do you have adequate resources? And when somebody says, when we see a no, 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 that right there is a red flag. So here are some scales, some formal scales, the brief resilient coping scale and the brief cope that might identify current overwhelm. If you don't have a scale or a questionnaire, absolutely just ask. I think we can get a lot just by talking talking with our patients and clients, asking them how they're coping, how they're holding up. And if they use the word overwhelm, which, now that I've brought this up, you might notice how frequently they do. That right there is a key that we may need to intervene and modify our approach and provide some supportive measures for them. So what might these supportive measures be? How do we break the positive feedback loop between the felt sense of overwhelm mentally and emotionally, and then the physiological state of overwhelm in our nervous system, the inflammation that perpetuates, and the decreased healing state that perpetuates, which then just kind of perpetuates more overwhelm. This is a self-perpetuating loop here. How do we get in and break this? So absolutely, the foundational step here is the Shoemaker protocol, the environmental aspect first, followed by the medical treatment. We have to get out of inflammation. Inflammation is something that perpetuates this cycle of overwhelm and inflammation and nervous system dysregulation. So addressing our environment and getting out of exposures is absolutely paramount. Same with CIRS medical treatment that is aimed to decrease that inflammation, and then to see nervous system and immune system and our endocrine system stabilize after that. But are there some additional things for the people who may be struggling to maybe comply? Maybe their getting out of environmental exposures is taking a long time and they're getting really overwhelmed and traumatized in the process. Or maybe they are triggered, a previous trauma has triggered them, they're overwhelmed, they're starting by time tolerating the binders because they're not detoxing and digesting well, they may be in a freeze response. What are some things that we can do to support these patients to tolerate the protocol better? Let's talk about some of that. So here are some professional nervous system therapies that are available that you can refer your patients to if you feel that they are appropriate. Somatic experiencing is a form of trauma therapy where clients are taught how to sense their own nervous system and when it feels dysregulated and when it feels supported. And there are certain activities that they learn how to do and certain mindsets to regulate their own nervous system and to release the trauma from their body. EMDR is another kind of body-based trauma therapy that's available and has some great evidence behind it. Psychotherapy and specifically internal family systems can be very effective. The Safe and Sound protocol, this is something that I'm actually trained and certified in. This is Stephen Porges' auditory reprogramming protocol that helps to increase the capacity of our autonomic nervous system and the resilience of our autonomic nervous system. Pretty fantastic. Neurotherapy or neurofeedback can sometimes be helpful. Sometimes patients may need to get a QEEG to assess their brain waves. And if they have some imbalances there, maybe too much beta activity where they should be having theta or alpha, that can dysregulate our nervous system and perpetuate a trauma response. And so neurofeedback in that area can be supportive. And then other body-based therapies like myofascial release, craniosacral therapy, acupuncture, and chiropractic can all help to release stored trauma and improve the integrity of our nervous system, structural alignment, and soft tissue to let go of the physical effects of trauma on our body. There are also self-care activities that our patients can participate in to enhance their own sense of inner sensitivity or inner safety. This can decrease the hypervigilance of their limbic system. They can, very much like somatic experiencing, they can learn their own triggers and cues and learn how to come into that rest and digest parasympathetic or ventral vagal state on their own with just a little support on the outside. There are neuroregulation activities that can do this, such as breath work, somatic practices that they've been taught that they can practice on their own, tapping or emotional freedom technique. There's so many different vagus nerve stimulating activities and gadgets out there that can help support this. Essential oils, deep pressure, limbic retraining, visualization, meditation, heart rate variability activities such as heart math, rhythmic movement, and music. This is the physical therapist in me, and in particular, the pediatric physical therapist. I'm used to working with very neurodysregulated children who see a lot of benefit from these types of activities, and I think they could really apply to much of our CIRS population. There are dietary approaches and supplements that can support gut health. Some of our foundational sources of potential inflammation, gut health, overall inflammation, with supplements and diet can certainly help. And then also prioritizing restorative sleep. So many times I think we forget how powerful sleep is on our ability to heal, on our immune response, on our nervous system response. So finding ways, despite the fact that most of us have low MSH and maybe a circadian rhythm that is not our friend right now, doing everything we can to set ourselves up for restorative sleep, even if it requires naps here and there, can really help to stabilize the nervous system. Let's talk about a few clinical support activities or modifications that could take place to enhance patient outcomes. So the first is to consider altering appointment durations to minimize patient overwhelm. I think so many of us have gotten away from the 15-minute patient appointments, which is fantastic. Our patients need much longer than that to share what's going on and to learn all that they need to learn from the clinicians. But some patients can't tolerate a whole lot without shifting into overwhelm. And so if you are regularly meeting with your patients for maybe an hour, 2 hours, 3 hours, they may have shifted into a state where they can no longer really hear and receive and assimilate what you're sharing, even though it's fantastic. And it could even do more harm than good if they are moving into that protective response and kind of freezing and shutting down. So something to consider, maybe more frequent appointments that are shorter. I don't know how you have your clinic set up, but just something to think about when you think from the patient perspective, what might minimize overwhelm. Also, offering written, well-organized treatment plans with action steps that are clearly outlined. So when your patients go home, if they have a paper that is very clear what they're supposed to do, what they're supposed to order, and how often they're supposed to take it, rather than a whole bunch of dialogue that may just be overwhelming to read or to kind of scan and understand. Just another thing to consider if you're not already doing that. Consider offering coaching support between appointments. So you may have a medical assistant or a health coach on staff who can check in with patients between their appointments with you just to see how they're doing. How did you feel about how the appointment went with the doctor? Did you understand what was presented? Do you have any questions? Have you been able to implement the treatments, and how are they going? How are you feeling about everything? Can we support you? That can go a really long way in helping patients from falling into those cracks and becoming overwhelmed on their own. Consider recording sessions so that patients can listen to them again. It can be overwhelming when you're in a fantastic, but maybe long and complicated doctor's appointment. So much great information is getting shared, but then you get home, and because of brain fog and executive function issues, patients may not remember all of it. And that great information may have, again, been lost or not poorly assimilated. So consider recording so that patients can go back, maybe share with their spouse, and really take in all that you have to share with them. And then lastly, be aware of how your language may be received by someone who is prone to a trauma response or limbic system hypervigilance. And lastly, we're going to talk about the coaching support that I provide to enhance coping strategies for patients. So talking about coping, before when we were talking about overwhelm, there were really two aspects to it. One was this incredible pressure or just too much on our plate. So there are a lot of burdens. And then the other aspect is insufficient energy or insufficient ability or resources to lift or to carry or to manage that overwhelm. So if we are, I'm sorry, of the burdens. So if we can address both aspects, then we're really getting at the heart of overwhelm. So by decreasing the weight of burdens, what do I mean by that? There are several ways that I do that with my clients. And one is to really assess what is on the plate. What is going on in their mind? What are all the different factors that are keeping them up at night and that they feel like are just too much to handle? Let's list them out. Let's look at the doctor's treatment plan. Let's look at it all, look at their environmental plan and see which ones we can just cross off. They're not even relevant. They're not even true. Maybe they can just erase those. Let's look at the ones that are relevant and let's prioritize. All right, what are we going to do this week? What's the priority here? What are we going to do this week? What are we going to do in week 2? What are we going to do in week 3? So break up or chunk up these prioritized pieces of information into bite-sized pieces. We also work on mindset. And so especially with people who have a hypervigilant limbic system, working on what is it that we're afraid of? What are these stresses? And can we reframe those fears and stresses and look at them in a different way where we feel like we have more capacity to manage them? And then enhancing our resources. So enhancing our ability to meet those demands. What do I mean by that? Well, we connect with inner strengths, with our personal values, spiritual resources, previous successes, and our sense of self-efficacy. These are some activities that I really enjoy doing with my clients to build our sense of agency and our ability to meet the demand. We also talk about sources of positive social support, and I do provide that through my some of the groups that I offer. If people don't have that kind of engagement with others that can actually bring us into a ventral vagal state, that connection with others can be very healing. I provide that for people who don't have that. And then access to professional resources. If I connect with people who are not yet working with a doctor or don't yet have an IEP, I enjoy giving them those resources so that they can stop spinning their wheels and feeling overwhelmed by working with people who don't know what they're doing. So here's a summary of what we've talked about. I hope you've enjoyed this. But what we talked about today was overwhelm and its definitions and how it is relevant to the CIRS population. We talked about the relationship between overwhelm and trauma. We discussed the physiological effects of overwhelm and perceived lack of safety and how these can serve as obstacles to CIRS recovery. I posed several questions and correlations to consider. We talked about identifying patients who are at risk of pathological overwhelm. I shared some strategies for helping patients break and prevent the positive feedback loop of overwhelm, inflammation, and nervous system dysregulation. Thank you so much for your time. I hope you enjoy this. If you would like to touch base, if you would like to discuss any of the questions that I posed for consideration, I would love to connect with you and talk more about this. Here's my contact information here at Simplified Wellness Designs. And I hope you have a great day and I hope you enjoy the conference.